Good morning, everyone. Today is the last day of Pan Pacific Neurosurgery Congress. So we have today a golf tournament, and if you want to bring your golf bag to the, so please take your bag here until 8:30. Today we will start from special lecture 3. Chairperson is Dr. Naoka Saiki. Please proceed.
So good morning, everybody. So let us start this session. First of all, thank you so much for Dr. Watanabe for selecting me as a moderator. Probably because I was chosen for this role because of my career and today's lecturer's career. About 20 years ago, we worked together. He was a great surgeon at that time also. So today's theme of the lecture is strategic planning for the skull-base malignancy. This is his Dr. Konno's main theme for his life. When I worked with him, we did a long operation, and even though it was the early morning, more than 24 hours operation, he showed up at the morning time, like 3 o'clock, 4 o'clock for skull-base reconstruction. So he was so much devoted to the surgery. In this sense, I respect him so much. So Dr. Konno, please begin your lecture.
Thank you very much, Professor Saiki, for kind introduction. And I am very glad to see you in Hawaii after 15 years separation. And good morning, everyone, for coming to attending the meeting so early in the morning. I am very pleased to speak on my experiences of treating advanced sinonasal carcinoma, which extended to cranial base, and its survival outcome. Sinonasal carcinoma are fairly heterogeneous, particularly in regard to histopathological type of the tumor, and they frequently extend to cranial base. This slide shows the histopathological type of the tumor in 33 patients which we have experienced in recent 11 years, which was treated by us in collaboration with neurosurgeon and radiotherapist in our hospital. And among these tumors, poorly differentiated squamous cell carcinoma and some of undifferentiated carcinoma are fairly radiosensitive. However, adenocyst carcinoma, ACC, olfactoneuroblastoma, adenocarcinoma, melanoma, and hemangiopericytoma are fairly resistant to conventional chemoradiotherapy. And factors to be considered to determine therapeutic strategy in these advanced cases are, first of all, histopathological type of the tumor and primary site and extension of the tumor in the patient's systemic conditions, including age. Among 33 patients, 8 patients were aged more than 80. And patient tumor, particularly tumor extended to sphenoid sinus with invasion of the lateral wall of the sphenoid sinus, were undetectable for us. And we divided, including all these factors into consideration, we divided our patient into 4 groups, from group A to group D. And this is the treatment and patient characteristic of group A patient. In this group, mean age was 52.4. This is fairly young compared to other groups. And the tumor extended and invaded anterior cranial base with or without intracranial invasion of the tumor. Histological type of the tumor were SCC and in 2, and adenocarcinoma in 1, and olfactoneuroblastoma Kadish type D or Kadish type C in 4 patients. In all patients, craniofacial resection was performed. And craniofacial transcranial resection was performed by neurosurgeon, and transfacial resection and endonasal resection was performed by ENT surgeon. In patients with ACC and adenocarcinoma, preoperative radiation 40 gray was performed using IMRT or Linac Xray. And in patients with olfactoneuroblastoma, postoperative radiation using IMRT 70 gray or proton beam 70 gray equivalent were carried out. And reconstruction of the cranial base was performed by using pericranial flap in every patient, supplemented by nasoseptal flap in 3 patients, free iliac bone graft in 2 patients, and vascularized free forearm flap or MC flap in 3 patients. And I want to demonstrate 4 patients in group A. And this patient aged 59 male with squamous cell carcinoma of the bilateral ethmoid sinus and frontal sinus, invading frontal dura and orbit. And adjacent to the tumor, we could observe subdural abscess just under the frontal lobe. This abscess was treated by incision drainage and antibiotics and preoperative radiation using Linac Xray 40 gray was performed. This is postoperative MRI. The tumor decreased remarkably, but biopsy around here showed abundant viable cell. So we performed unblocked resection, including bilateral ethmoid, frontal dura, frontal sinus, and orbit, together with anterior skull base. And the effect of the dura was repaired with fascia lata, and large defect of the anterior cranial base was reconstructed with cranial graft, flap, and iliac bone graft, and vascularized MC flap. This is 3 years after operation. This is grafted bone covered by vascularized MC flap. This patient is doing well without cancer for 11 years at present time. And this is 59 years old female with highly differentiated squamous cell carcinoma of the ethmoid sinus, extending to the frontal sinus. This tumor was treated by preoperative radiation using Linac Xray 40 gray, followed by unblocked resection of the ethmoid together with part of the maxillary sinus and frontal sinus, together with anterior cranial base. And this defect was reconstructed by pericranial flap and iliac bone graft and free fascia, free forearm flap. This is CT 4 years after operation. And this patient is doing well with the cancer for 11 years after operation at the present time. This is 45-year-old male with large olfactoneuroblastoma invading intracranially from bilateral nasal cavity, bilateral ethmoid, and squamous sinus. This tumor was dissected transcranially and transfacially, and the defect of the cranial base was reconstructed with pericranial flap and vascularized free form flap. And this patient was treated post-operatively using proton beam 70 gray equivalent and these chemotherapies. However, this patient developed recurrence at the sphenoid ridge 3 years after the operation, and he died of distant metastasis 5 years after the operation. And this is 44-year-old male with fairly localized olfactoneuroblastoma. In this patient, unblocked resection of the ethmoid sinus and septum and frontal skull base, and leaving the mucous membrane of the septum of this side intact. And the effect of the skull base was reconstructed with pericranial flap and this side of the nasoseptal flap. This is a post-operative CT 1 year after operation. This type of reconstruction was the most frequently used in patients with localized tumor. This is the survival outcome in group A patient. This patient, described before, died of local recurrence followed by distant metastasis 5 years after operation. However, other 6 patients are living without cancer with median follow-up period of 6.2 years. This is treatment patient characteristic of group B patient. The mean of the patient are almost 70 years old, and 4 out of 8 were aged over 70 years old, and 3 were aged more than 80 years old. And the tumor extended to anterior or middle cranial base, but they did not extend intracranially. And histological type of the tumor were SCC in 5 patients, SCC adenocarcinoma, and melanoma in each 1 patient. Full dose preoperative radiation was used in every patient using IMRT or Linac Xray 6 gray in patients with SCC and other carcinoma. And in patients with SCC and melanoma, we used proton beam or CyberKnife, and all patients were treated with concomitant superselective intraarterial chemotherapy, followed by unblocked resection of the tumor. Primary reconstruction was performed using vascularized free forearm flap or MC flap in 5 patients. I want to show 2 patients in this group. This is 5-year-old male with highly differentiated SCC of the maxillary sinus invaded extensively into the orbit and infratemporal fossa and pterygoid fossa and nasopharynx, and with the bony destruction of the middle cranial base. This patient was treated by IMRT 60 gray with concomitant intraarterial chemotherapy in 4 courses. This is CT and MRI after chemoradiation, and the biopsy showed grade 2B radiation effect, which shows remarkable effect, however abundant viable cell, cancer cell present. So unblocked resection, including the orbit, was performed in this extent. And the entire wound surface was covered by using vascularized free MC flap with rib cartilage. This is CT 6 years after extended total maxillectomy with primary reconstruction using this size of vascularized MC flap. And the large palatine defect was reconstructed with this MC flap. And the defect of the middle cranial base was covered by MC flap. This patient is doing well for 7 years after operation. Another patient, 81 years old male, with adenocarcinoma of the ethmoid sinus extended to the anterior cranial base. This patient was treated by Linac Xray 60 gray with concomitant intraarterial chemotherapy. Tumor decreased remarkably in size, and biopsy showed grade 3 radiation effect, which shows almost no viable cell. So in this patient, intranasal endoscopic operation was performed to clean the residual mass in the ethmoid sinus. And this is MRI, 10 years after endoscopic endonasal operation. This patient is doing well without cancer. And he's now 91 years old. This summarizes survival outcome in group B patient. This patient, 81 years old female with highly differentiated squamous cell carcinoma extended to the orbital apex, died of distant metastasis in 2 years. In this patient, radiation effect, histological effect, was limited to grade 2B. However, other patients, other 7 patients, are living without cancer with median for a period of 5.1 years. And this is treatment and patient characteristic of group C patients. And in this group, tumor was fairly localized at the posterior portion of the anterior cranial base. And the histological type of the tumor was SCC and Olfactoneuroblastoma and hemangiopericytoma in each one patient. All of these are radioresistant tumor. So in this group, in these patients, tumor was dissected first by endoscopic endonasal operation in 2 patients and transfacial resection 1 patient. In the young patient, post-operative radiation using proton beam in 2 patients and carbon ion in 1 patient was carried out. And in 1 patient, immediate reconstruction using vascularized 3 and 4 flap was performed. In this group, I want to show 1 patient. This is 70 years old female with hemangiopericytoma, which developed from anterior wall of the squamous sinus, embedded partially into the squamous sinus. This tumor was treated by endoscopic endonasal operation followed by radiation using proton beam 70 gray equivalent. This is MRI and CT 4 years after treatment. Patient is doing well without cancer for 4 years at the present time. And this is survival outcome in group C patient. This patient with adenosine carcinoma around the cranial base, was treated by carbon ion. He lived without cancer for 12 years, but 12 years after radiation, he developed radiation-induced SCC squamous cell carcinoma. Instead of ACC, he developed squamous cell carcinoma at the cranial base. He died of secondary cancer 13 years after operation. Other two patients are living without cancer. And this slide shows the overall survival curve in group ABC patients who were treated by combined therapy, including operation. 5-year and 10-year overall survival rate were 93.8% and 82% respectively, and very good. And this is treatment and patient characteristic of group D patients who are treated without operation, non-surgically. And tumor developed in this group in 2 patients developed from the sphenoid sinus and invaded the surrounding structure. In the other 13 patients, tumor developed from sphenoid or maxillary sinus or nasal cavity and extended to sphenoid sinus or anterior or cranial base. Histological type of the tumor was SCC in 10 patients, and ACC and melanoma each 2 patients, and undifferentiated carcinoma in 1 patient. In all patients, full dose radiation was performed using proton beam in 8 patients and carbon ion in 1 patient, and IMRT or Linac Xray in 6 patients, with concurrent super-selective intra-arterial chemotherapy in 12 patients. I want to demonstrate 2 patients in this group. This is overall survival curve in group D patients who are treated non-surgically. 5-year and 10-year overall survival curve were 33% and 22% respectively. And at the present time, 4 patients are living without cancer with median follow-up period 5.9 years. And I want to demonstrate 2 patients in this group. This is 63 years old female with undifferentiated carcinoma of the maxillary sinus, which extended into orbit anterior cranial base with bone destruction of the middle cranial base and extended into the sphenoid sinus and nasopharynx. This patient was treated by proton beam 66 gray equivalent with concomitant intra-arterial chemotherapy. This patient doing well without cancer for 5 years at present time. And this patient, 64-year-old male with highly differentiated SCC developed from ethmoid and sphenoid sinus, with bone destruction of the anterior cranial base and embedded into the orbital apex with bone destruction of the lateral wall of the sphenoid sinus. This radiological finding, from this radiological finding, we consider this patient unresectable and treated this patient with Linac Xray 6 gray with concomitant intra-arterial cisplatin. This is CT after chemoradiation. radiation effect was considered fairly good. However, PET CT and biopsy 5 months later showed recurrence of tumor at the inferior and lateral portion of the sphenoid sinus. This recurrence was treated by radiation using carbon-ion 40 gray equivalent. And patient had been doing well for 4 years, but he suddenly developed massive bleeding from sphenoid sinus from ruptured internal carotid artery. This was treated by embolization coiling of the internal carotid, and patient developed 6 months later meningitis, and he died. And I wonder if I had requested neurosurgeon to resect this residual tumor, to resect surgically, together with internal carotid artery and sigmoid sinus, instead of asking radiation using proton beam, we might have been able to save this patient. I don't know the result, but this patient died of late complication of radiation. And this slide shows the causes of treatment failure in 11 patients of group D patients who were treated non-surgically. 4 patients died of local recurrence, and 2 other patients who had local recurrence were treated by radiation using proton beam. Both of them died of ruptured internal carotid artery in 4 years or and 6 years after radiation. The other 4 patients died of distant metastasis, and this one patient with adenomyocystic carcinoma of the sphenoid sinus, she was treated by carbon-ion. She had been doing well for 10 years without cancer. She suddenly developed massive bleeding from ruptured cavernous sinus, secondary due to radionecrosis of the sphenoid bone. We had 4 patients in this group with highly differentiated carcinoma. Out of 4 patients, 3 patients died of recurrence of tumor, and 1 patient died of distant metastasis. So, particularly highly differentiated SCC were fairly difficult to control without operation. In conclusion, craniofacial resection is the most reliable treatment for sinonasal cancer invading the cranial base, as long as the tumor is resectable with free margin. And advanced sinonasal cancer without intracranial invasion could be controlled by preoperative full-dose radiation with concomitant superselective intraarterial chemotherapy, followed by unblocked resection of the tumor in 82% of the patients. 10 years overall survival rate of unresectable sinonasal cancer treated non-surgically was 22%, and it was most difficult to control the advanced, highly differentiated SCC without operation. And finally, carbon-ion therapy and radiation using proton beam for sphenoid cancer had risk to induce osteonecrosis of the sphenoid bone in 6 to 10 years after radiation, resulting in carotid rupture. Thank you for attention.
thank you so much, Dr. Kono. I saw your sincere attitude to the aggressive treatment for the skull-based malignancy. Any questions from the floor? So, from neurosurgical viewpoint, let me ask you one thing. So, you said there was the one patient of ICA rupture, and you said if we have some, without that radiation therapy, patient might not have the ICA rupture. So when you review this patient, do you think neurosurgeons should have done the bypass surgery to avoid the radiation?
Yeah, if a neurosurgeon could dissect the tumor invading lateral wall of the sphenosinus, invading carotid artery and sigmoid sinus, I think we could have saved patient. So if we can confirm the safety of dividing carotid artery and sigmoid sinus.
So in your 33 cases, no such cases of the bypass surgery before the removal of the tumor. No such cases.
That's right. Okay. When I was Chiba, we operated with you before radical operation. We made bypass from the contralateral carotid artery, external carotid artery to the middle cerebral artery.
Okay, thank you.
Thank you for your beautiful lecture. You were telling us tumor case with malignant tumor case, but the same period, how many did you experience vascular disease in the same field?
What disease?
Vascular.
Vascular.
For example, aneurysm or dural sinus or something like that. Vascular disease in the skull base. How many cases do you
know? No, I don't know because we don't take care of vascular disease. ENT.
Yeah.
Yeah. All patients go
to very strong breathing from the nose. Sometimes you are treating the case like that. Everything is neurosurgeon?
Yeah, almost all doctors, patients go to neurosurgical department. Yeah. And sometimes we are called to see the patient. So it's very rare.
If you find, for example, aneurysm or if you find some vascular disease, you are sending the neurosurgeon to that patient.
Yeah. Yeah.
Yes.
I'm Dr. Kinoji, and thank you very much for excellent lectures. When I was a medical student 35 years ago, every student was so amazed at your enthusiasm and the energy, and also the very super surgeries. And still you're doing. So it is very amazing. Thank you very much for your great lecture. And my question is not so good question, but you do radio chemotherapy before surgery, and which patients should do the radio chemotherapy before surgeries? And also, the second question is, after radio chemotherapies, the histological examination was really important for next step strategies. But in the large tumors, so every site of the biopsies cannot tell the whole story. So which part should be examined? It is my question.
If the tumor is very large, it's difficult to examine all part, just easy part. But we dissect entire tumor after chemoradiotherapy, principally.
Yeah. How do you decide?
Oh, I see. Especially SCC Squamous carcinoma are fairly sensitive to chemoradiotherapy. So we do all patients with squamous cell carcinoma and dissect after radiochemotherapy.
Thank you very much.
Okay, so thank you so much, Dr. Kondo. Let's finish this session.
Thank you very much, everyone.
Thank you, Dr. Naokazu Saiki, as the chairman, and we call on Dr. Hidenori Kobayashi as the chairman for the next session.
Okay. I'm Dr. Kobayashi. I will chair the rehabilitation session. The first speaker is Hijikata, Dr. Hijikata from Tokyo General Hospital. Please.
Good morning, everyone. Thank you, Chairman. Today I will talk about combination therapy with transcranial magnetic stimulation and rehabilitation. At first, I'd like to introduce our hospital. Our hospital is located in Nakano, Tokyo, Japan. Location: it takes 6 minutes by train from Nakano to Shinjuku. Total bed 451, including 192 rehabilitation beds. This picture is new advanced medical care building opened in April 2017. The picture is the day rehabilitation service opened in January 2018. We have 3 stimulations and filial 8 coil. We perform TMS with rehabilitation under the direction Professor Masahiro Abo from Jikei University. We perform over 932 cases TMS with rehabilitation. This slide shows a therapeutic concept using such interventions. We think low frequency RTMS over the we think low frequency RTMS over the non-regional hemisphere and with intensive OT is more effective than regional hemisphere. With this combination therapy, we can get a more effective response for upper limb function. Novel intervention using repetitive TMS and intensive occupational therapy. We named this concept Neuro. RTMS use filial 8 coil and stimulator. One session, 1,200 pulses. Into 20 minutes. Site of stimulation is motor cortex of non-regional hemisphere. Intensity 90% of motor threshold of FDI muscle. This is the schedule 50-day protocol, Saturday version, start version. During hospitalization, each subject underwent 22 treatment sessions, each comprising 20 minutes for the application of low-frequency RNs, TMS, and 120 minutes of intensive OT. 2 sessions were conducted per day. This is intensive OT program. 2 components. One is one-to-one training, finger training or shoulder training. Second is self-exercise. We evaluate the upper limb motor function with these score or test: FMA, WMFT, FAS. This slide presents including criteria for neuro. Number 1, Brunstrom stage for hand, finger of 3 to 5. Number 2, age at intervention between 18 to 90 years old. Number 3, time between onset and intervention more than 12 months. Number 4, history of a single stroke only. Number 5, no cognitive impairment. Number 6, probable plateau state of functional recovery. Number 7, no active physical or mental illness. Number 8, no recent history of seizure. Number 9, no contraindication for RTMS in the guideline suggested by Wasama. Please look at the Japanese TV clip about neuro. The Japanese has been dubbed into English. This video is before TMS. At first, check her right hand function. Lifting test. She could not lift the weight. Over 5 years, she didn't use her right hand. This is a video of after TMS, the day of leaving this hospital. This is lifting test. 2 weeks ago, she could not lift the weight. After the TMS, she could lift the weight. So in just 2 weeks, her right hand recovery dramatically. In order to the further improvement of function, we need to consider the accuracy improvement of neuro. Thank you.
Thank you for a nice presentation. Any comment or question for this presentation? I have a question. You showed the earliest patient perform this treatment 12 months after the stroke. The most latest case, how many months, how many years?
10 years.
10 years.
5 years.
That patient recovered after this treatment.
Hand function recover. Finger recovery. This.
Any comment or question? Good. Thank you for your presentation.
Thank you.
Next presentation will be Dr. Harashima from Tokyo General Hospital.
Good morning, everyone. Thank you for the chairman. Some abstract and content is different, but please understand the situation. Today, I'd like to talk about the effect of the walking assist robot. We have many walking assistant robots like following. Honda makers is pushing gate assistance. Diver house maker is pushing more long distance walking. Yasukawa maker is passing for ankle movement. Toyota maker is for different functions like monitor and sound assistance. But this is advisable for patients who have ear memory. After G maker is bionic leg. It is easy to carry anywhere. This machine is easy and speedy to attach. The device is good for knee support. We could have a good result by using this bionic leg robot device we want to share with you. This is video shows bionic leg. This device can be placed easily with the foot of the sensor is the shoes, firmly fastened with Velcro and wire. It can be installed in 5 minutes. it supports the patient motion depending on the weight. Also, she can get stability. It assists the knee when standing and sitting. And according to the working ability, bionic leg robot supports the knee. This is a case information. He was 80 years old male, acute epidural hematoma. He had head injury during rugby games. This is CT, pre-operation, post-operation. He is a big person, as a Japanese, 185 centimeter, body weight 100 kilogram. This is time course. This is the operation days. Rehabilitation started on the bedside from PODC. POD 17, from this time, we started to use bionic leg. He was working with full assistance. He could stand and sit independently after 1 week using bionic leg. He could walk alone after 2 weeks using bionic leg. I'll show you the actual training at the next slide. This shows the training of POD 17. This is when he started working with bionic leg. He cannot move, not at all by himself. This shows the training of POD 17. This is when he started working with bionic leg. Only 1 week after using the bionic leg, he could work with partial assistance. After the 2 weeks using bionic leg, he could work alone without assistance. As you can see, body balance is not good yet. Conclusion, we experience this is very good result with bionic leg. Using this device, we could have very good and useful training with safety and reduce of assistance, especially for the big person. And finally, he left our hospital on March 13, 2017. He can play soccer. Thank you for your kind attention.
Thank you for your presentation. Is there any question or comment? Good. One question. Yeah. You showed 5 maker Honda and Daiwa. Yes, cover and so on. How many company? How many machine do you use in your hospital?
Maybe I think 5 makers.
Or
Yes.
any question? Thank you.
Thank you very much.
My talk today is the effect of RTMS, TMS on patient with hem paralysis or aphasia. Okay. So Dr. Drake and me a long time ago, such a famous neurosurgeon might have hemiplegia after his complete or beautiful operation. This is inter-hemisphere beam inhibition. Pyramidal cell send the axon to the other side and innervate the GABAergic inhibitory cells. So, pyramidal cells inhibit each other. This is a intact brain, the stroke brain. This side excitation became weak because of this stroke, and the inhibition become bigger on this side. So RTMS on the healthy side suppress the inhibition, and then stroke side excitation become bigger relatively. This is the concept of this treatment. So in chronic stage, we use 1 Hz RTMS. In acute stage, we use this high frequency RTMS. This is an experimental study performed by us. This is a circular coil and a figure 8 coil. Figure 8 coil was invented by this Dr. Bueno, our colleague. This is a figure 8 current density. It is pretty, we can stimulate brain very precisely. Posterior anterior current make the biggest motor growth potential. The other direction, no use. This is a point, but away of this point, motor growth potential, we cannot observe the motor growth potential 5 millimeters away from this point. We can stimulate the finger muscles, brachioradialis, biceps brachia, leg tibialis anterior. Okay, we 64 patients. We have 64 patients, motor deficit 61, and only 3 patients of aphasia. This is age and period, 3.7 years after stroke. This is 2.5 years after stroke. This is a grading of extremities, more mild paralysis, severely impaired. This is we classify this in 5 these tests in 5 grades. And this is the machine we used, mouse stimulation, and navigation brain site, and 1200 stimulation, 1 hertz, 1200 stimulation on the intact brain. 2 times a day and for 10 days. This is intensity is 90% of threshold. After TMS, the patient had these therapy. This is a stimulation movies, guide coil. Oh, sorry. This test was performed for the evaluation before and after treatment. This is a aphasia test. These 3 tests. These are pictures for the OT treatment. This is a pre-treatment and after treatment. Oh. So also treatment and after treatment. This is the result. All patients improved. This is our phase test. We have only 3 cases happening. These 3 cases tend to improve after this treatment. So RTMA is a good treatment option for hemorrhage or failure due to CBD, even in late period after stroke. Thank you for your attention. Okay.
Hello, my name is Roger from Maui. Thank you for a beautiful presentation. I just read somewhere that the FDA in the US had accepted this technique for treatment of depression. How is this in Japan?
Oh, in neurosurgeon rehabilitation center, just do this treatment. I'm a neurosurgeon, but in rehabilitation, also attend this rehabilitation center. So this work together, we perform together this work.
Yeah, very impressive. So, yeah, thank you.
Question or comment?
Okay, thank you. Nice presentation. My husband also do this RTMS. So our hospital not only RTMS, former presenter with intensive rehabilitation. We think it's a very important. Your hospital also this rehabilitation.
Yes, I showed after treatment with stimulation RTMS 2 times a day, and after RTMS in the morning, the 1 hour occupational treatment. After in the afternoon, another RTMS, then occupational therapy. So we do same pattern. Okay. Thank you for your attention.
Thank you, Dr. Kobayashi, and we call on Dr. Hiroki Koto as the chairman for the last session. Now we come the honor guest selector of 9th Pan-Pacific Neurosurgery Congress, and the last presentation of this Congress.
The special lecture is being presented by Dr. Treatment Mathisen, Professor of University of Copenhagen. I will introduce Dr. Treatment Mathisen. Dr. Treatment Mathisen was born in Sweden in 1957. He received MD from Medical School of Karolinska Institute in 1983. To my surprise, during he attended Karolinska Medical School, at the same time, he studied mathematics and ethics and philosophy from 1972 to 1982 at Stockholm University. In 1988, he received PhD in neurosurgery, neuroimmunology, and virology. In 1993, he received certified neurosurgeon at Karolinska Hospital. From 2006 to 2016, he served as an assistant professor of neurosurgery at Karolinska Institute. Since 2017, he is working as a clinical professor of neurosurgery at the University of Copenhagen. He has also served many positions. He has been a chief editor of Acta Neurotherapeutica since 2015, and he is co-chairman of WFNS ethics committees since 2017. Today, Dr. Professor Mathisen is talk about pineal cyst. We are looking forward to the especially surgical indication of him. Professor Mathisen, please.
So thank you very much for the kind invitation, for the kind introduction, and to Dr. Watanabe, Dr. Fukushima, all friends. It's such a pleasure and such an honor, not only to be here again, but also to be part of this circle of friends and highly skilled neurosurgeons. So today I would like to speak a little bit about pineal cysts because I think this is a very enigmatic topic. I will unfortunately not be able to solve the problems, but I will be able to discuss them a little bit. Of course, nowadays, at least my children, when they start looking for evidence, they turn to the internet. And if you look for the pineal gland on the internet, you will have a very quick explanation that the pineal gland is our cosmic antenna. And they suggest that we should decalcify and nourish our pineal gland. This is not my topic of today. I will speak a little bit more about the actual pineal cysts that we do see as surgeons. And we know that the pineal cysts are extremely common findings. Autopsy series, very high incidences, radiological series also, at least if you accept very small cysts. The more sizable cysts, larger than 5 millimeters, again, common findings, and I guess common knowledge in large parts of the world are that these are completely incidental. In fact, our colleagues in Czech Republic, Vladimir Denish's group, conducted a worldwide survey accepting the fact that some pineal cysts may be very large and cause hydrocephalus, Perinose syndrome, and growth of cysts. They did this questionnaire survey, and they came up with a result that there is consensus regarding treatment of pineal cysts among neurosurgeons in the world, and the consensus is quite strict. The pineal cysts should be resected if and only if they cause hydrocephalus, Perinose syndrome, or if there is documented growth, because that could be a sign of a different pathology, such as appendicitis cystic. However, we also have a number of colleagues around the world that have experience of surgery, direct surgery of pineal cysts, that do not cause a mass effect. And there are a few publications. I think Charlie Teo was first to publish in 2015 a series on around 20 patients, pineal cyst resection in the absence of ventriculomegaly or Perinose syndrome. Last year we had one involved neurosurgery from Denish's group, conservative as surgical treatment of patients with pineal cyst. Again, around 20 patients operated, and we have Ada from Oslo, results of surgery in symptomatic non-hydrocephalic pineal cyst. Again, around almost 30 patients operated, 20 with radical microsurgery, 6 shunted, and 6 punctured. The results are very similar in these 3 series. The microsurgically removed cysts had no serious complications, and there was an 80 to 90% very significant relief of headaches or complete recovery from headaches. So the same results in the 3 series. Still, of course, this is a very controversial result in the world of neurosurgery. One thing is that the results are the surgeon's evaluations, which is probably problematic. One thing is that we as surgeons are quite sure that we are offering the patient a good therapy when we indicate the surgery. The other thing, of course, is that we also realize that patients who do trust us do not want to disappoint us when they report their outcomes. I've unfortunately seen this many times. And there are no controls in these series, and that's the other thing. People sometimes talk about placebo, but modern science is more and more showing that the placebo effect is probably not very relevant. Instead, what may be relevant, especially when we're dealing with chronic conditions such as headache, is that the chronic condition in itself fluctuates in intensity. And at any time you can expect that if you have a lot of intensity, if you have bad disability from headaches, and you may go to surgery, even if you wouldn't go to surgery, things would be better half a year later. This phenomenon is called the regression to the mean. If you have a fluctuating chronic condition, you will get better once you are at the top of the worst situation. So the indications are controversial, and we are with a number of gaps of knowledge regarding these pineal cysts. We still wonder if the pineal cysts are associated with headaches or if that's an epiphenomenon. Does surgery ameliorate the headaches? And there are 2 different things. Is there an association between cysts and headaches, and is there a causal relationship? Is there a cause and effect between cysts and headaches? And the practical question, and when we talked about indication, should we offer surgery for the patients with pineal cysts? And again, what's the natural history? There is one piece of evidence for cysts, for the association of headaches with cysts. And this is a prospective, very well conducted case control study by Seifert et al. It's not Volker Seifert, our friend, it's Seifert, the neurologist. But regardless, this is a good study, and they found a clear statistical association between headaches and the cysts. But this study was never replicated, and this is the only study that really makes a problematization of it. So we have been collecting patients I have seen at the Karolinska. We had a geographical representation of the population, and all newly detected pineal cyst patients were referred to neurosurgery, regardless of whether they had headaches or were found for different ways, as incidental findings or workup for other conditions. So we'll be looking a little bit into the natural history and the association with headaches. The material is 154 consecutive patients, most of those females, and with a mean age of 37 years. So the way we handle these is initially we recommended follow-up annually. This is a historical series going back to the 1990s. So initially we had annual follow-up. Later we realized this was not necessary nor cost-effective. So later on we just made a 1-year follow-up. 130 patients followed our recommendation, 24 did not. And out of those 130 that were followed, 4% decrease, 5% increase, but never symptomatically, and 91, or if you use a sensitivity analysis, 92% remained stable. 3 of these that increased were operated. So taken together, natural history is beneficial, and this is not a progressive condition, and you cannot expect patients with pineal cysts to develop serious mass effect or intracranial hypertension. 103 patients had headaches, and these headaches were classified by the headache specialized neurologists. Primary headaches would be migraine, tension type headaches, or trigeminal autonomic cephalgia. We only had migraine and tension type in this series. So, of all the patients, I'm sorry, some of the figures do not seem to add up completely, but it's because they had to be rounding up figures. They became a little bit strange, but approximately correct. So 44% were non-specific, and out of these, a large minority improved spontaneously within a few months, probably indicating this is the kind of regression to the mean phenomenon. 54% primary, mostly tension type, silent migraine, and some combined. 2% secondary headaches, one was a facial pain and one was borreliosis. So what's the association between the pineal cyst and headaches? We only looked at the pineal cyst that were larger than 5 millimeters. Out of the 154 patients, 103 were detected during workup for headaches, and 51 workup for other neurological symptoms or CT scanning after trauma. So you can see that the relationship here is almost the same as in Seifert's series, where 2/3 of the cyst patients had headaches and 1/3 did not. We can also see that of all patients who turn up at neurological emergency ward, approximately 1/5 have a complaint of headaches, at least in Sweden, the United States, and Europe. We can see that 1/5 had headaches, 2/3 of pineal cyst patients had headaches. So just this observational statistics give a very strong support that pineal cysts and headaches are associated. This is a statistical association. The question is whether there is also a causal relationship. We will come back to that. So with the follow-up of headaches of the 103 symptomatic patients, 1/4 reduced symptoms and reported reduced symptoms and improvement of headache, and 1/4 reported worse headaches. Some of these were later operated, but majority did not want surgery and thought they were doing well anyway. So I'm not sure really how we should evaluate this report on the follow-up of the quality and the intensity. The other thing that one thinks about with pineal gland, of course, is sleep and melatonin deficiency. As many as 1/5 of all patients reported sleep disturbances and/or were treated with sedative hypnotics. So there seems to be an association here as well. It seems, I mean, it's not rocket science to try to treat patients who have an affection of the pineal gland and report sleep disorders with melatonin. And we offered 13 patients melatonin. We offered more patients melatonin, but 13 accepted the offer. Out of these, 7 reported very good effect on headaches and sleep, and 6 found no difference. So it appears that there may be something. Hard to evaluate. Small numbers. We looked at all the pineal cysts larger than 5 millimeters and then compared size with symptoms. And I must say it was a little bit surprising because we're beginning to think that there is a clear association. We think there is a clear association between headache and the cyst, but there is no association between the size of the cyst and the headache. They had almost the same size regardless of whether they had headaches or not. The same regarding sleep disturbances and the same regarding response to melatonin treatment. Now, how should we treat this cyst? This is an overused Lexell citation that I think we hear in almost every second conference nowadays. If you only have a hammer, the world looks like a nail. Then again, it's an extremely relevant citation because as surgeons, it's natural for us to try any lesion, to treat any lesion with surgery. The question is, does it work? I showed you a few series where it was reported to work. I will show our own observations of 12 patients and the observations we made on these. This is the first patient that I would like to present. It is a patient who had at first headaches and secondary amenorrhea. And we had a very aggressive endocrinologist who unexpectedly came with a patient and wanted us to do surgery, not the opposite. So she thought there was a causal relationship between the cyst and the secondary amenorrhea. We were a little bit skeptic and reluctant, and informing that it still is this major surgery, complications may happen, etc. But she got worse and worse, and after half a year, she was so in pain from headache, constant headache with sometimes worse attacks. She was only just screaming on the floor. So we operated, and surgery went well. She was immediately free of headaches, and after a few months, she also recovered endocrinologically, which was a little bit unexpected, and we became a little bit more enthusiastic regarding this surgery and operated more patients. So we did offer surgery to more patients who had cysts size-wise a little bit larger than 10 millimeters maybe, with a local mass effect, with severe headaches that interfered with regular life. Patients had neurology consultation, medical treatment, and still could not tolerate headaches and really pushed to be operated in spite of being informed that this is potentially dangerous surgery. I would like to mention another patient because two cranial cyst patients in our series had undergone stereotactic puncture by Peter M. And he described so beautifully how I think his first patient he did was done under local anesthesia, severe headaches when he was taken into surgery, and then he punctured, and immediately the patient said, "Doctor, what did you do? My headache just left." The immediate relief at puncture. Patient doing well, follow-up scanning okay, but symptoms recurred after half a year. New scanning, cyst has recurred. Patient operated with microsurgery, and now this is long ago, this is more than 20 years ago, and the patient still is relieved of headaches. And the 12 patients we did microsurgery on, so that was one of them, suffered from headaches. Majority reported as non-specific, one migraine and, sorry, should be one, sorry, I think this is on both, two combined tension type migraine. Here, mostly supracerebellar, some occipital transtentorial. As I showed you, two stereotactically punctured first, and after recurrence undergone microsurgery. And all of these patients had resolved headaches, and the one patient with a secondary amenorrhea had reversal of this. So again, this looks very good. Can we trust it? What was possible to do with this series, which has not been done previously, but these patients have been followed after their surgery for a mean of 7 years, a minimum of 2 years. And what speaks against the phenomenon of a regression to the mean is that none of these patients has had the same kind of headache and the same intensity of headache back again. 4 patients did report recurrent headaches, but at much lower intensity and controlled medically. So I think it's reasonable to assume from analysis of the material that surgery did have a causal effect. And the other patients in the material responded sufficiently to conservative treatment, and the asymptomatic patients were followed without any clinically relevant progression or headache symptoms developing. So what is the mechanism? Is melatonin the thing? We know that patients with migraine and cluster headaches have low melatonin levels. We know that melatonin increases pain thresholds and that deficiency of melatonin would decrease it. We know that melatonin can be beneficial for primary headaches. In the material, 7 of our patients responded well to melatonin therapy. So there is a linkage between melatonin, pineal gland, and headaches, but the problematic logic is that pineal cyst patients with headaches and low melatonin, presumably low melatonin, were operated with removal of the last part of the pineal gland, and they got well with even lower melatonin. So I'm not sure that the melatonin is the causal link we are looking for. Other ideas, Seifert suggested that there would be intermittent hydrocephalus from obstruction of the cerebral aqueduct. Ada thinks there is central venous hypertension from crowding in the pineal recess and pressure on the internal cerebral veins. It has been suggested that there are trigeminal fibers in the pineal gland, and these are stretched in the cyst patients, or some other local effect. The symptoms are not related to size. You can see that the mass effect is almost identical regardless of patients have headaches or not. So I think the mechanisms are largely unclear. Melatonin is not a likely explanation. The symptoms are not size related. Ada shows that there is no effect of shunting. So patients who were shunted for headaches and pineal cyst did not respond. They did not get well from their headaches. So again, the intermittent hydrocephalus, I think, is probably not a reasonable explanation. And surgery of the pineal cysts appears to be beneficial. So one would be prepared to offer, I think, surgery to many patients with severe headaches, provided because one could have fairly wide indications as long as the surgical risk is minimal. And it seems to be possible to do very nice microsurgery with minimal risk, which leads me to a presentation of one case here. Pineal cyst, you see it down there. Very severe headaches, suffering, and of course offered surgery. And this is the operation in a lateral position. Luckily enough, not very many veins at all, so we made a paramedian approach and spared the midline veins. And there are of course lateral veins also. We will come back to that because that's the clue of why I'm showing this case. You can see the thickened arachnoid behind it is the cyst. You can see that my dissection isn't excellent because I wasn't happy with that scissor. So we changed scissors. This was not the right scissor, a little bit bulky, and so difficult to work with. But we did not have the appropriate instrumentation available, so went on operating. And you will soon see, maybe one should have made a pause and gotten the right instrumentation. You see there is a little bit of venous blood coming here, trickling down the side. And looking up, we see the lateral vein, which I tore, and was inexperienced enough to coagulate completely, thinking that usually these veins can be coagulated with impunity, according to a lot of the literature. And then we continued operating, no problems. Spared all the other veins, but coagulated the lateral vein. After some dissection, some additional dissection. Cyst is sharply dissected and removed. Surgery is finished. And it still looks fine. You can see there is holding the brain a little bit, but no need for retraction and very nice and smooth. So, finished surgery. Uneventful complete removal. I went to play squash and then I got a phone call. The patient was fine when she woke up. I got an urgent call, the patient was now comatose. And this is the urgent CT scan. You can see some venous bleeding and huge swelling. So, of course, emergency decompression, which was necessary because she was comatose. She recovered eventually after long term in the ICU. Residual symptoms. She is back at work. She is free of headaches, but she has a handicap that was completely unexpected. Although we, of course, warn patients that everything can happen, this was completely unexpected to me. And if 1 out of 12 patients ends up with a complication like this, one has to rethink about the indication. So let's go back and comment the gaps of knowledge. Are the pineal cysts associated with headaches? I think definitely yes. Zyfer's paper and again our patient consecutive patient series has exactly the same distribution between patients with headaches and without among the cyst patients. Does surgery ameliorate headaches? I think yes, in selected cases. We don't have a large prospective trial, but the unique patients, if you analyze them, are best compatible with the theory that surgery can actually ameliorate headaches. Is there a causal relationship? I think this is highly unclear because several of the causal relationships that have been put forth are not, don't seem to explain the outcomes. What about the natural history? But usually the symptoms decrease with time, and we didn't have any case with imperative surgical indication developing during the follow-up. And should we offer surgery for patients with pineal cysts and headaches? Well, before the case I showed, I would have said we should have wide indications. Now, realizing maybe we shouldn't have that wide indications. So this is, again, a slide not to take so seriously. On the internet, we have the pineal detox checklist, where they recommend drinking of non-fluoridated water and taking your vitamins, but I think there are some things to bring up here, and that is to have positive friends, which I think we do in this group of neurosurgeons. And my conclusion is that I'm convinced from what we have seen in the literature and from our series that there is a yet non-defined subgroup of symptomatic pineal cyst patients who do benefit from surgery. I think there is circumstantial evidence that this benefit is real and connected with the surgery. Again, surgery is acceptable if low morbidity, and I just wanted to show you how the unexpected can ambush you with a venous drainage. So still, the unexpected complications are to be expected. The patients we are willing to offer surgery are the ones with severe headaches, cysts, 10 to 15 millimeters with a local mass effect, intractable medically. The patients must push for surgery after honest disclosure of your knowledge base and results. Selection must be strict, and I think it's a task for all of us to try to find causal explanations for this phenomenon. Thank you very much.
Thank you, Dr. Matthisen, for your stimulating lecture for diagnosis and headache and surgical. Is there any question or comment? I have one question.
Yes.
Some of the spinal system increasing the size.
Sorry,
increasing the size of bigger.
Increasing size. Oh, yes.
Now, is there any characteristics of imaging, CT or MRI, such as high intensity work?
Well, I don't think we could select which they were. It was highly unexpected. The main reason, and what people tend to think, is that most of the benign pineal cysts are just benign pineal cysts, but among them, some pineocytomas, some cystic pineocytomas may be hiding, and the ones that increase in size are actually the pineocytomas. I realize it's also a little bit difficult for the pathologists to make a clear differentiation between cystic pineocytoma and the benign cyst. So it could be that it's only the pineocytomas that increase in size. But again, many things we don't know, because there is a peak incidence of cysts during late childhood, early adulthood. So one would expect that there is, maybe they grow for some time. Then again, in our series, the distribution between sizes was not age dependent. So I think we can be sure that the risk is not very high, and I think a one-year follow-up is completely sufficient for these patients.
Thank you. Is there any question? And then one more question.
Yes.
How long we have to follow up the MRI for spinal cyst? 2 or 3 years, not enough?
I think 1 year is enough.
1 year.
1 year. I think 1 year is enough. We started with 15 years, and then we gradually decreased to 1 year because we didn't see anything happening between year 1 and year 15, most of them. And we had 24 patients who didn't listen to all our advice and didn't do any follow-ups, and none of those needed surgery. Well, none of those had any symptomatic progression that would require surgery. So even I could think that maybe the patients we did operate more for, we had a few with progressive signs of the cyst than for progressive symptoms. I'm not so sure that maybe I would be a little bit more hesitant to operate nowadays.
Thank you. Is there any question? Dr. Fukushima? No. Thank you, Dr. Matthisen.
Thank you.
Thank you, Dr. Goto, and thank you everyone for your attendance at this meeting. And today we have a Pan Pacific Golf Cup, and we'll start a reception from 12. And so before 12, you go to Kanapari Golf Resort by yourself, and you can use trolley. The departure time is 10:50 and 11:30 from Rotary at first floor. And you can get information at the reception desk. Thank you.